Imaging in general, you could think of a straight X-ray, dental X-ray or whatever, ultrasound, right? They're all different kinds of images. Volumetric is where you say, we really want the full 3D volume. The CT scan, if you've ever been in one, they look very much like the tomotherapy unit, very similar. A CT scan works by delivering several slices of X-rays from all different angles. That's all it is, all these different angles. And it comes back and creates this volumetric pattern of you, this image. So what you end up with after a CT scan is a three-dimensional model of you. So that's one of the first things that happens when you come into to get radiation treatment nowadays. An MRI, it stands for magnetic resonance imaging. It also gives you this 3D volumetric model of you, but it's based entirely different than X-rays, like the CT scan. It's based on magnetization, and so you get a very, very high, powerful magnetic field. It orients all of your protons in one direction, along with the magnetic field, which is not dangerous, I might add. Okay, completely harmless. And then what happens is a little pulse knocks them out of their alignment, and then they come back in slowly. And depending on what tissue is around them, that changes how fast they do this. And so you can say, I've got some tissue, like maybe my tumor has a bunch of solid stuff, or maybe it's mostly fatty, or it's liquid, right? I can tell the difference between fat and muscle and all these things. So MRI is fantastic for being able to differentiate between various soft tissues. And so oftentimes MRI will be used along with a CT scan. So an MRI, like the CT, you get a volumetric image, you get a model of yourself. But MRI uses magnetization, strong magnetic field. It's perfectly harmless, and that's a wonderful thing about MRI. What it does is allow you to differentiate between, say, water and fat, vascular tissues, all sorts of various things in great detail. So very often, if you've got a tumor that's somewhere where you've got a lot of blood vessels, or you're trying to figure out what kind of tumor is it, right? Is it a solid tumor, or is it maybe just a cyst that just has liquid in it? MRI is the way to go, so we use that a lot. PET stands for positron emission tomography. And again, you get a volumetric image, another model of you. And I should tell you, you can walk away from these scanners and have a CD with this model of you. And you should do that, because it really is. It shows everything that's inside you. It's a wonderful thing that we have. The PET, they inject a radioactive tracer, a very small amount. It's virtually nothing. Sounds a little scary, but it's really not dangerous at all. This radioactive tracer is actually attached to a sugar molecule. Your tumors are thirsty for sugar. They're growing quickly. That's one of the hallmarks of them in most cases. So what happens is the sugar molecule will get trapped inside of the tumor along with this little radioactive tracer that we have. So you end up with, if you do have any tumors anywhere, with this radioactive stuff, and then the PET scanner waits and looks for the emission from those areas and reconstructs it, and then you get an image of where you have the most metabolic activity. Look at all the different modalities in general. Forget CyberKnife or tomotherapy or anything. Many, many years ago, the first kind of radiation was really 2D. Kind of sounds like two-dimensional. So I might have a couple of radiation fields from opposite sides, and I shoot them, right? And they make this dose distribution in the middle, right? It's not fancy. I may put a block somewhere to try to shape it a little bit. That's a 2D plan. Ultimately, in 1990s, more or less, people started to play with things a little more sophisticated and said, well, what if we, instead of doing, fields like that, what if we had several of them from different angles, right? And what if now we shaped these beams so they were in the shape of the tumor we're trying to hit? Sort of like a beam's eye view, right? From different angles. That's 3D. And the question is, in 3D planning, what's my optimal positions for my beams? Because I might be talking about 2, 3, 7, or 8 beams, but not a lot more. And I've got to find optimal positions for them and optimal shapes. Right. Just so when you say 3D volume, I don't want a cross section of your body. I want the whole body, right? And you know, sometimes we may take, you know, if you have a tumor, a cancer, or something in the middle of your body, we just need these scans that cover that region. But still, it's three-dimensional. There's actually algorithms that can be used that will literally take these, you know, in 3 dimensions. You don't talk about pixels like you do on a photo, but you talk about voxels. So voxels are 3-dimensional pixels. You can match these images voxel by voxel, right? So say, when do you get this perfect correlation, so forth. There's lots of different methods. So we have some automated methods that we use. There's a lot of groups doing a lot of research to try to, you know, ultimately the holy grail would be able to, you know, perfectly match everything from all these modalities, even if there's little changes between when you know, I did my CT scan and then I was, you know, crooked or in a different position when I did my MRI, putting all these together. So it's a very active part of research, and then you know, ultimately you may just look and move things around, especially in the area you're interested in. Time is the 4th dimension. Not quite as slick as general relativity, but you say, all right, we've got time, which means what happens if let's say I'm breathing. Well, I could have a snapshot of my CT at one moment, and then as I breathe, another snapshot. So you can actually find these online too, where people will have 4D CTs, and it's essentially a bunch of CTs over the course of your breathing, and you see how your internal anatomy changes as you breathe, which is really, and they can do this with MRI as well. So you can imagine you've been diagnosed with a tumor. Now the question is, what's the extent of it, right? Is there anything we missed anywhere? You know, maybe you've got some kind of biochemical marker that told you you've got some kind of tumor growing, but all this imaging says exactly where it is and exactly extent of it, right? So the CT is very good for spatial resolution, and it's what radiation therapy is based on. And then what we do is we put these PETs and these MRIs on top of it, so that we get, you know, all this information, this multimodality model of you, and each of them can have different utilities depending on the tumor. At one point, someone thought, you know, what if instead of having just this static beam, and maybe it's a nicely shaped beam, right? It goes like, you know, but what if instead of just having that static beam, we divided it up into 100 or 200 little tiny beamlets, each of them independent. Okay, so now I could have several different beams from different angles, like the 3D, but each of those beams now is divided into like many dozens or hundreds, right? Well, I get a lot of degrees of freedom now. I get a lot of things to play with when I'm doing a treatment plan. So suddenly, that oddly shaped tumor that was very close to some organs we didn't want to hit, which was very, very difficult to get a good plan with on 3D, now becomes actually really easy, right? So you suddenly come up with dose distributions that are vastly better than anything you got with 3D. And so in the last decade or so, most facilities are doing some form of IMRT for at least some of their patients. Well, so tomotherapy, the machine delivers in a rotation like that, but what's actually being delivered is divided into 64 tiny little slices. And these things go on and off, on and off and on. It's called a multi-leaf collimator type of it. And that's what it is. It's actually just making, not only is it a circular beam, but it's also a circular beam that's divided into ultimately, you know, hundreds and hundreds of little beams. That's how that's high MRT. I've got my images, my CT, MRI, and so forth fused on. I've got this 3-dimensional model of you. And now we've got to figure out, well, where's that tumor? Where are the things around it? Maybe liver or kidney, right? Organs you don't want to touch with radiation. And I've got to figure out a plan. I've got to do the contouring of this. I've got to create the radiation plan. And I've got to validate that it's actually going to work for the machine. So all of this process of coming up with a radiation plan is called dosimetry. Well, dosimetry is a process that can take It can take a day, it can take a week, right? There may be a few iterations. You may try out something and go, it's not quite what we want, so let's go back to the drawing board. We've had certainly times where we've gone back and said maybe we need to use a different machine than what we initially intended to do. So, it's a back and forth process, but usually dosimetry is done within a few minutes. Contouring, as it kind of sounds like, you're putting contours around what you want to treat. And it literally is looking slice by slice. Maybe you have some little tools like a pen. You can really think almost like painting in some ways. You're taking the CT image, and now you're trying to actually put digital structures around it. So it's time consuming in some cases, but it's a fundamentally important part of the process, obviously. You have to get that right. We get this contour, we're all happy with it, and then we say, we want to get this amount of dose. We want to spare this, we want to do this, right? So we have our objectives. And then the treatment planning part is to say, come on, machine, give us a plan, right? Now, we have a lot of great algorithms that work, that help us with it, but they're not perfect. And so we're not yet at the point where we can just push a button and get the optimal treatment plan. So the treatment plan is saying, look, I've got all these angles I could deliver radiation from, right? I've got all these intensities I could deliver it from. What combination creates this radiation distribution? And so the treatment planning part is running the program and trying to figure out the best way to do it, helping it out using the automated features and so forth. Typically, patients don't ask for their treatment plan, but they are welcome to have it. And in most modern systems, they can actually get a little CD, or you could just get screenshots showing the radiation dose distributions. And absolutely one should, if you're at all curious, take a look at them.